Good morning, dear student. Topic of today's lecture is the premature contraction and myocardial infarction. Learning objectives of my lecture are: at the end of my lecture, you must able to answer the following. What is premature contraction? What is atrial extrasystole? What is ventricular extrasystole? How we are going to define the myocardial infarction, ECG patterns of myocardial infarction, and the changes of ionic composition of the blood during the myocardial infarction. Now the premature contraction. As we know that the impulses arises from the pacemaker of the heart, that is the SA node of our heart. If any abnormal impulses arises because of the sum of the irritable foci within the heart, or if there is artificial extra stimulus is given in the form of irritable foci, it responds by contracting prematurely. It is called extrasystole, or the premature beat, or the ectopic beat. The cause of ectopic beat, premature beat, or extrasystoles are due to the local area of the ischemia, small calcified plaque, toxic irritation conducting pathway. When abnormal impulses is formed, the abnormal waves are formed. So in the given diagram, the ectopic P wave is formed, abnormal P wave is formed, or it is known as the atrial premature beat. Premature contraction, it is the ectopic cardiac rhythm. The abnormal cardiac excitation produced either by an ectopic focus, which is present in the heart. Spontaneous beat called as the premature or the extrasystole. Now this premature contraction can be studied under the atrial extrasystole and the ventricular extrasystole. As the name suggests, atrial extrasystole, so abnormal or premature beat, it is formed during the atrial depolarization. A premature P wave with aberrant configuration is formed. Abnormal PR interval is there, but the QRS complex and T waves are normal. The subsequent cardiac rhythm is shifted and it is reset because the premature beat discharges the SA node, which then repolarizes and fires after the normal interval. Significant, it occurs normally. The patient may or may not be aware of an occasional irregularity in the cardiac rhythm. Ventricular extrasystole, it arises from any portion of ventricular myocardium. When we see the ECG pattern, there is the absence of the P wave preceding the QRS complex. The atrial depolarization that follows the premature ventricular beat arrives while the AV node is still refractory and therefore it is not conducted to the ventricle, creating the compensatory pause in the ventricular rhythm. That means we know that normally ventricle contract as a result of impulses generated by the SA node. If artificial extra stimulus is given in response, it responds by contracting prematurely, which is called the extrasystole. Now, the next normal impulses coming from SA node to ventricle usually falls in the refractory period of extra contraction. So, the ventricle does not respond to it. This period of inactivity is known as the compensatory pause. Now we know that the Refractory period of the heart is long. That is, for the ventricle it is 250 millisecond and atria it is 150 millisecond. Extending up to the end of the systole. Because of this, stimulus given during systole and early diastole are ineffective. This inexcitable period is known as the refractory period. By the time the stimulus become effective, the muscle start relaxing. So this property show that there is the contraction is necessarily followed by the relaxation. In the diagram, we are seeing that ectopic and abnormal QRS waves is formed and there is absence of the P wave. Long RR interval is there and two RR intervals are formed. So there is the abnormal RR interval, absent of the P wave is there. And inverted T waves are also generated. So this is all about the immature contraction or the premature atrial contraction, premature ventricular contraction. Now we are going to discuss the myocardial infarction, is also known as the MI. The ischemic necrosis of the part of the myocardium which occur when the coronary blood flow ceases or is reached below a critical level. When the blood supply to the heart is less, then the part of the heart where the blood is not reaches, it become the ischemic in the nature. If this ischemia is prolonged, it led to the death of the patient. Now the angina pectoris, it is the ischemia causes accumulation of the P substance which causes substernal pain, and this substernal pain referred to the inner border of the left arm. So during the myocardial infarction there occur the substernal pain which is referred to the inner border of the left arm. In myocardial ischemia, there occur the elevation of the ST segment because of the decreased resting membrane potential, delayed depolarization, rapid repolarization. In the given diagram, normal resting membrane potential of the heart is minus 90 millivolt and there occur the depolarization, plateau form and the repolarization. While in the ischemic tissue there is a decreased resting membrane potential and it is the minus 60 millivolt. There is the delayed depolarization as compared to the normal tissue and there is a rapid repolarization. The diastolic vector, it is from the negative toward the positive terminal. In the ischemia, it is the minus 60 and it is the minus 90 millivolt. Systolic vector, it is from the negative toward the positive side. Influences of the ischemia on the ECG. With subendocardial ischemia. In subendocardial ischemia, the duration of endocardial action potential becomes shorter than the epicardial action potential. Depolarization starts in endocardium as the normal, but the endocardium repolarizes first. Repolarization will occur earlier than in the epicardium. Both depolarization and repolarization direction are oriented from endocardium to epicardium. The voltage vector, however, is formed away from epicardium, and therefore an electrode positioned over the epicardium will record a negative T wave. In subepicardial ischemia, the depolarization is late as compared to the subendocardial. Here also the depolarization and repolarization direction are oriented from the endocardium to epicardium. So epicardium is the lastly depolarized or depolarized. First the endocardium is depolarized and the repolarized. So in the diagram there is the shift in the subendocardial ischemia. There is the shift of the baseline toward the upside, so that there is the downward deflection of the T waves. And in the subepicardial ischemia there is the upward shift of the waves or the baseline. When upward shift of the baseline is there, so the T waves, it is the elevated. ECG pattern in acute myocardial infarction: elevation of the ST segment, depression of the ST segment, as we already discussed. In the lead overlying the area of the infarct, there is the elevation of the ST segment and depression of the ST segment in the lead on the opposite side of the area of the infarct. Now, in the old cases of myocardial infarction, the ST segment returned to the normal. Appearances of Q wave in some of the lead, and increase in the size of the normal Q wave in the some of the other leads occur. Physiological basis of ECG changes in acute myocardial infarction. The alteration in ECG are due to the injury current, which flow from affected to the unaffected part of the myocardium. The affected part of myocardium get depolarized partly or completely, but does not get repolarized rapidly. Now the current of injury, it is from the normal cell toward the ischemic cells, from positive toward the negative side. Now the diastolic vector, in the diastolic vector, the current of injury, it is from the negative toward the positive, systolic from negative toward the positive. So direction are the opposite to each other. Current of injury at the resting membrane potential or current of injury during delayed depolarization and rapid repolarization. Now, infracted area at the rest. In the diagram, there is infracted area and the normal area with their different polarities there. When there is decline in the resting membrane potential, the ischemic necrosis of myocardial fibers causes the breakdown of the cell membrane, increase in potassium efflux, increase in sodium influx. Inside the infracted cell, less negative as compared to unaffected area during the ventricular repolarization. The current flow into infract from the unaffected area. During depolarization and during the repolarization. Infracted area slowly depolarized, while in the repolarization the infracted cell easily get repolarized. In depolarization, inner side of infracted area attain positivity later than adjacent area, so inside become negative. Extracellular current flow out of the infract. During repolarization, because it get repolarized easily, opening of potassium channels surrounding cells are still opening of the potassium channels occurs and surrounding cells are still depolarizing. Current flow toward the recording electrode over the infracted area. This increases the positivity. Now, ionic changes of the blood during the myocardial infarction. Hyperkalemia, increased concentration of the potassium is known as the hyperkalemia. When the plasma potassium concentration is plus minus 7 milliequivalent per liter, the ECG changes are the T waves is very tall and slender and peaked. When the potassium concentration is a plus minus 8.5 milliequivalent per liter, there is the absence of the P wave, broad QRS complex, tall and slender T waves is there. Hypokalemia, mean which the concentration of potassium is less. When the concentration of potassium is plus minus 3.5 milliequivalent per liter, there occur the prolonged PR interval, ST segment depression, prominent U waves are there. When the concentration of potassium is 2.5 milliequivalent per liter, PR interval is lengthened, the ST segment is depressed, the T wave is inverted, the prominent U wave is seen. So these are the changes in ionic composition of blood during the myocardial infarction. So this is all for today's lecture. Thank you.